Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello, welcome back. This is Adam Rosen. You're listening to the Total Knee Tips and Pearls podcast. If you've been listening, again, total knee, right? But past few episodes have been a lot more about classifications revolving around the hip. So we're going to jump a little bit further down the leg to the knee, and I'm going to go over the Anderson classification for bony defects, sort of analogous to the Paprosky classification with regards to hip. Again, before we get started, please, if you've just found this podcast, thanks for tuning in, and please subscribe. If you like what you're hearing, leave a review. That really helps other people like you that are looking for this information find it. And again, people have asked before, like how I got started and where am I doing my hosting. Again, that's done through Buzzsprout. They've been really helpful. I'm thinking about at the end of this sort of sequence of classifications, what I'd like to do is actually start doing some more interviews with some of my colleagues and other orthopedic surgeons around the country. So Buzzsprout's great with that because they have a bunch of videos that's actually really helped me start to delve into what other equipment I need to make sure that I get good sound quality when I'm doing these one-on-one interviews, especially now, with COVID, being able to maintain distance across the table from someone so we can actually have a conversation and still maintain our social distancing. So without further ado, let's jump into it. So the AORI classification, this was classified and described a couple different times. So Engh first wrote about this back 1997. It was titled A Classification of Bone Defects in the book Revision Knee Arthroplasty. If you do have it, great. It's page 63 to 120. And then also has classification with Dr. Engh and Dr. Ammeen. This was the classification in pre-op radiographic evaluations. This was published in Ortho Clinics of North America in 1998, an April edition. And again, in classification and alternatives for reconstruction. This was an instructional course lecture review article back in 1999. And again, I'll put all of those in the show notes. So if you want to go back and PubMed those and read the articles yourselves, that would be great. And, just as a little aside, it was when I was doing my fellowship, it was actually a great experience that I was able to take part in. It was offered. It was done through DePuy. And what they actually did that year was offered all of the total joint fellows. And I think they do something similar now. I think it's been modified, obviously, with COVID and things like that. But what they did is they were actually able to fly all of us out. We were able to get to meet Dr. Engh and the rest of the gang there at the Anderson Orthopedic Research Institute. Bunch of lectures that were given to all of those fellows. And then we were able to watch a bunch of live surgery. So it was a really good experience. And it was neat, too, because, it was people that were going through fellowship at the same time that I was. And, these are people that I've run into at other meetings over the years, even though we did our trainings, different institutions and practice in different parts of the area. So, really, really great and interesting sort of educational thing that I was able to take part in 16 years ago now, 2005. Without further ado, let's get into this. So when we talk about this, we talk about types, 1, 2, and 3, and 2 is broken into 2 subgroups, A and B. And we talk about types as a whole, but also when you define them, you can define it as a type 1 would be a T1 or F1, depending on, where the big defect is. So if we talk about type 1, whether or not we're talking about femur or tibia, the way that this is looked at is, we're looking at minimal bone defects. The metaphysis is intact. There's, really no issues with the stability of the implant. And, also all of your collaterals and things like that are all intact. So that's your type 1. So that's if you're lucky, revision, it's loose, no major issues. And when you treat these, you can pretty much treat these with your regular revision implants. If you have a small little defect or void, you might fill it with some extra cement or do some impaction bone grafting techniques depending on where it is. But these are small. These are small enough that you wouldn't cut excess bone just to fit in a cone or augment or wedge or sleeve or something like that. So now we move on to type 2. So again, you can have a type 2A or you can have a type 2B. And again, this can be on the femur tibia. So you describe it as a T2A or F2A or T2B or F2B. And what we're talking about for 2As, this is metaphyseal bone damage, but of one side. So one femoral condyle or one half of the tibial plateau. And also you start to see some loss of the posterior condyles. So for these, when you're treating these you're going to be, again, if it's really small, it's still big enough, but it's still smaller than your smallest augment. You might fill with cement or most likely use an augment. You could use bone graft or bone grafting techniques with impaction grafting. You're going to use some sort of modular things such as like a sleeve or a cone that you'll fit in there. And I think these are become a lot more, common now that they're available. So, back when sleeves and cones weren't there, it was your options were, an augment or cement. And there's other things. So I'll talk about kind of two things at the end that you could use as sort of an alternative to keep in your bag of tricks and things that you can do and use down the road. Maybe you get in there and you're not prepared and, you have a bigger defect than you thought. Now 2B. So again, T2B or F2B. This is a metaphyseal bone damage of both condyles. So both sides of the femur, medial lateral, both sides of the plateau, medial lateral are involved. And again, depending on the bone, if it's contained, you might just fill it with cement, depending on the person, their age, their bone quality, their activity level. More commonly, you're going to put in, as opposed to impaction grafting, most likely in this day and age, larger augments, larger cones, larger sleeves. Stage 3. Stage 3 is massive bone loss. So femoral 3, tibial 3, massive bone loss. Large portion of the condyles and plateaus are gone. This can even involve your collaterals and your patellar tendons. That's a big thing that a lot of times you get in there, and that anterior tibia is like a shell of bone with just the patellar tendon attached to it, and it's very easy to break it or avulse it off, so we got to be cautious. So these are a bigger deal. These you have to prepare for. Maybe you're calling in some bulk allograft. Maybe you get some sort of custom implant, but I think for the most part, a lot of times with what is available now as far as revision stuff, you can usually get away with other things. But this is where you're most likely going to be using a sleeve or a cone, having a hinge available because you're not sure about the stability of the collaterals. And if there's a significant amount of bone loss that you're thinking, I don't even know if I can get a hinge in this person, this is when you want to back yourself up with a DFR and have those available. So, it's really important to kind of know classifications. And I think, people are fearful, I think, more of the femur and the acetabulum and the hip, I think, than the knee. I think just kind of people think, well, I'll just open up, see what I got, and I'll just kind of throw some augments and cones. But it is good to have that plan because, again, you don't want to get caught with your pants down and think, oh, I just got a revision, it's a loose implant, and then get in there and find out you needed a hinge or, it was so weak just in retraction you broke something off, or getting the implant out, you broke it off, and now you need a DFR. So, having this thought process really, again, is good as a classification if it helps you diagnose not only the issues, but the treatment, so that's what we're looking for. So, again, two other things, little tricks. So it is a great trick to always know that, maybe you have a smaller defect that's not big enough for an augment or a sleeve, but it's still fairly sizable that you got to do something to protect it. So this is great where you can actually do the rebar technique where you can use screws to put them in there. And this way, when you cement, the cement then bonds to the screws to offer more structural support than just trying to create like a little, wedge or triangle of cement somewhere off the side of, say, like your tibial plateau, or even like on one side of your femur, one condyle. It's not big enough for an augment here or there, distal or posterior, but it's still a hole. So you can use a screw and then use that screw and screw head as a way of basically using a rebar technique when you put your cement on to hold that in. The other thing, which I think, was one of those things I was lucky enough to get trained in with one of my mentors, Dr. Lotke, and you don't really see as much anymore, I think, because of the advent of all of these great, titanium sleeves and cones. I mean, the things that are available now make these massive reconstructions so much easier. But one of the things that we used to do was impaction grafting, and it really is an art that you have to understand. I mean, you have to have the right pore size of the cancellous chips. You really have to impact the hell out of it to make sure that it's impacted down. But, we used to use the wire mesh. So, if you had an uncontained defect, say on the tibial side, what you'd be able to do is, cut and fasten your mesh, screw it into the bone that's remaining at the bottom, use your reamer, make your implant, kind of put it in there, and then impaction graft around the area and really pound that area down. So now when you cement it, you're hopefully restoring some of that bone stock on that tibial plateau. Where I think, nowadays, a lot of us get into massive bone loss. You just drop your cone, and you can freshen up the bone if there's still bone still high on one side, build everything off of that. And so it's made lives a whole lot simpler due to all these great new tools that we have in our armamentarium. But again, you need to be prepared. So if you're not prepared, that's where you're going to get caught with your pants down. And unfortunately, the person that's really going to suffer at the end of the day is your patient if you give them a less than optimal implant that either fails early prematurely or is unstable and needs another operation. So again, I'll put this all in the show notes again, but again, type 1, minimal bony defect, pretty much fill it with cement or impaction grafting, doesn't compromise the stability of your implant. 2A, 2B, metaphyseal bone damage, but 2A is one side, one condyle, one half of the plateau, medial or lateral. 2B is metaphyseal bone damage, but both condyles, both femoral condyles, both sides of the tibial plateau. And 3 is massive bone loss. Those are the ones you got to be prepared. Collaterals, tibial tubercle may be involved, may avulse. You may need allograft. You may need a hinge. You may need a DFR. So more information for you. Kind of a quick listen before you run into the OR next time you're doing that big knee revision. And again, if you haven't already, subscribe. Please, if you like what you're hearing, leave a review. Until next time, stay safe. You've been listening to the Total Knee Tips and Pearls podcast. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.